Hello, I'm Jody Saarvala. I'm a professor of respiratory therapy at the Michener Institute of Education at UHN. And today I'm here to talk to you about lung protective ventilation for acute respiratory distress syndrome, which is actually what we are seeing in COVID-19 patients. I don't have any disclosures to share. And I've provided a few slides with references for where I have gathered information for this presentation. So I won't go through them in detail, but you can see that there are some journal articles as well as the CSRT, some videos from them, as well as some hyperlinks to some of my slides that you will see today and you can access later. As well, some of my PowerPoints have been taken from the Michener Institute of Education and revised for this topic. And finally, one of the textbooks we use at our institute, I used for some of the information. So you'll see that it's Pilbeam's 6th edition and several different chapters that I gathered information from. So our objectives today is that we're going to briefly take a look at the different lung injuries that can result from mechanical ventilation if we're not mindful of how we are applying it to our patients. I'm not going to dive deeply into the pathophysiology. I just want to make you aware of the injuries that can occur if we are not mindful of what we're doing. We're also going to discuss how to ventilate an acute respiratory distress syndrome patient, which I will just refer to as an ARDS patient going forward. We're also going to look at the topic of a baby lung when it comes to an ARDS patient and what we need to know specifically with that regard. I've pulled together 3 different references for different protocols on how individuals ventilate ARDS patients. So I have the ARDSNet protocol that we're going to take a look at. We're going to take a look at the University Health Network's protocol, and then the Center of Excellence for Mechanical Ventilation and their recommendations. So there are very similar things that overlap between the protocols, but just slight nuances between them. So you can take what you like for your hospital and use that approach. We're going to take a look also at driving pressure and how that can affect our ventilation, as well as how to use our recruitment to inflation ratio, which is a newer concept that we are using to decide an ARDS patient. And finally, I found a ARDS order set that is available for access. So if your hospital decides that they like it, I'll show you where you can actually access it for your hospital to use moving forward. Okay, so why do we need to be using lung protective strategies? So we can cause many different pulmonary effects to the lungs, and so we're going to be discussing a little bit of those. So as I said, I'm not going to be diving deeply into the pathophysiology, but making you aware of the injuries that can occur. And so some of the 4 principal ones that I'm going to talk about are some of the lung injuries that can be separated into ventilator-associated lung injury, as well as ventilator-induced lung injury. We're going to take a look at air trapping and how that can affect, how that can cause harm to the lungs, as well as if we're over-aggressive with the amount of oxygen that we are providing our patient. And also, I'll touch on it a little bit about the imposed work of breathing that can result as when I'm focusing a bit more on initiating ventilation when the patient might be sedated, and there might not be any patient efforts at this point, so the work of breathing may not be a problem moving forward. Okay, so ventilator-associated lung injury is a result from our mechanical ventilator, and things that can cause ventilator-associated lung injuries are air trapping, as I mentioned, that we're going to take a look at. We can cause barotrauma, which is trauma from too much pressure being used, or volutrauma, which is a result of using excessively large volumes. And then also ventilator-associated pneumonias fall under this category as well, which can develop once intubated for more than 72 hours. When we look at our ventilator-induced lung injury, we're talking about, rather than how we're mechanically ventilating or things that are happening externally and migrating down into the lungs, we're now talking at a level within the lungs. So we're talking about the tissue that's now distal to the terminal bronchioles. So we're talking about our respiratory bronchioles, our alveolar ducts, and our alveoli. So it's usually at a microscopic level. And so the injuries that are common from villi are different biotraumas, which we'll discuss in further detail, as well as shear stress, surfactant depletion, and atelectatic trauma. Okay, so air leaks or barotrauma. So this is a result of using too much pressure. So again, this is usually pressures that are exceeding 30 to 35 centimeters of water. And what can happen is they can cause damage to the alveoli and actually cause them to rupture. And this will result in extra-alveolar air, pneumothorax, subcutaneous emphysema, our pneumomediastinums, our pneumopericardiums, and pneumoperitoneums. So things that put us at a risk of having barotrauma is strategies if someone's using higher peak inspiratory pressures, so our PIP, or along with low PEEP levels. So as we'll talk about driving pressure a little bit later, this results in a greater change in pressure between the two levels, our highest and our lowest pressures between inspiration and expiration. And then that can cause barotrauma due to those high pressures. Also, if we are using higher levels of PEEP along with higher tidal volumes, that combination will also result in higher peak inspiratory pressures and higher pressures within the lungs and at the alveoli, and can cause damage to the alveoli at that level. Next is bullous disease. So this is if you have a patient who's coming in with COVID-19 or an ARDS picture, but they also have a history of emphysema or tuberculosis, we know that we can rupture the bulli and cause air leaks. So we need to be more mindful of that, as well as necrotizing pneumonias can lead to barotrauma. So within the barotrauma, the different types that can occur, as mentioned earlier, are our subcutaneous emphysema, our pneumothorax, pneumomediastinum, and pneumoperitoneum. I'm going to expand a little bit more on our first two, which is subcutaneous emphysema and the pneumothorax. So to the right, you'll see just a picture of the area where the barotrauma tends to occur. So we have our ruptured alveolar bases. So this is where the rupture can occur. And we're going to talk about shear stress, which can occur between two alveoli. So this is down in the area where these events can happen. So here you can see interstitial emphysema, and you can see that there is air going into the subcutaneous tissue. These little white bubbles are symbolic of air or gas bubbles going into the tissue, and I have a slide that talks about this in a bit more detail. Then we have our pneumothorax, which is where gas is filling the pleural space, the pleural space between the lung and the chest wall, and it can start to compress the lung and affect the ventilation. And again, I have another slide that will talk a bit more detail about pneumothorax. I don't have another slide on pneumopericardiums, but you can see the gas is actually gathering around the sheath of the heart and compressing the heart, which can lead to cardiac tamponade and different issues with hemodynamic stability. Okay, so subcutaneous emphysema, it may or may not be life-threatening. It depends on the extent of it. So if you have subcutaneous emphysema, again, it's air in the subcutaneous tissue, and it often occurs around the neck. It's a side effect from placing tracheostomy tubes, so it can be a complication of tracheostomy tube placement, which occurs around the neck, chest, and face. And you would see that the skin appears puffy. Sometimes it can cause the eyes to actually swell shut. And when you actually press on the skin in the area where the subcutaneous emphysema is, it feels like little air bubbles, like almost like popping bubble wrap. So it's a little crunchy, and you can feel the air releasing and moving to a different area as you push on it. So like I said, it's not normally dangerous. However, if it becomes a pneumomediastinum, where it's leading to compression of other anatomical features such as the esophagus, great vessels in the heart, then it can lead to cardiac tamponade, and that can be deadly for our patients. The next one was our pneumothorax, and so this can lead to partial lung collapse or full lung collapse. And so initially, if it's a mild pneumothorax, you may not see huge changes in ventilation, but as the pneumothorax grows in size, we will have issues with our ventilator. We will have high pressure alarms that are sounding, low volumes, depending what mode you're in, will depend on the alarms that you see. So if we're in a volume control, so an AC/VC mode, we'll get increased high pressure alarms, and we'll see our PIPs, or our peak inspiratory pressures, actually rising. And if we're in a pressure control, so a VCPC, or sorry, an ACPC mode, you will actually see decreases in the tidal volumes being returned to the ventilator, as some is being lost through the pneumothorax. If you take a chest x-ray, you may see that the mediastinum is pushing away from the side where the pneumothorax is. So if the pneumothorax, for example, is on the left side, you may see the mediastinum shift towards the right side, and vice versa. So as the air enters the pleural space, it can't escape, and if it continues to accumulate, then we can have tension pneumothorax arise. which can be life-threatening. So in a tension pneumothorax on chest x-ray, you absolutely should see a shift in your mediastinum. You can actually see a shift of your trachea, and we do need to get a chest tube into individuals, not just if it's a tension pneumothorax. Any pneumothorax will need to drain using a chest tube. So our next slide is volutrauma. So we can cause damage to the lungs by over-distending any areas that are compliant with too much volume. So if we don't think about the size of our patient's lungs, and we use aggressively high tidal volumes, then we can over-distend and cause damage to the alveoli. So for example, if we were to remove the high pressure and strap the lungs tight so high pressures would not rise, we would see that the volume would actually cause over-distension to the lungs. And so generally, volutrauma is associated when our transpulmonary pressures are getting higher than 30 centimeters of water. So when we're looking at some of these lung injuries, and especially in ARDS, the lung isn't affected the same way throughout the entire lung field. So we have some areas where the lung is normal compliance, and we have other areas where there is poor compliance. And so naturally, the gas is going to want to flow to the easiest route, which is our normally compliant lung. So they might actually take on more volume than we expected. And so again, so it's not just in our settings, but also just the nature of having normal lung with diseased lung. The normal lung can take on too much volume and get over-distended and damaged. So there is a way we can look for over-distension, and that is with our volume pressure wave, our loop. So this graph is accessible on your ventilators. So usually there's waveforms and loops. And so you would find the loops function on your ventilator. And so you would pick the pressure volume loop. And so when we look at this, we can see that the lower line here is actually inspiration. So you can see here we have our PEEP. So our inspiration is starting at PEEP and it's slowly inflating. And at this point here, you can see that for each centimeter of water, the amount of volume the patient is gaining is increasing quite nicely. And as we get to the top here, we're seeing that for each centimeter of water, we're not really gaining much volume. And this is us trying to force in additional volume into the lung and causing over-distension. This is a sign that we can maybe back off on our volume or our inspiratory pressures, depending on what mode of ventilation you have set up. So we don't want to see this flattening beak on a pressure volume waveform. And then this upper portion is actually the exhalation of the patient. So that's them exhaling. So this area here is where we're seeing the over-distension. So if we drop our tidal volume or drop our inspiratory pressures or our pressure control, we can have a loop that doesn't flatten out and will actually sort of finish here and recoil back down naturally. Okay. So trauma as a result of atelectasis, so atelectic trauma, is a cause from the alveoli collapsing on exhalation and then re-expanding on inspiration. So each time this is happening, we're causing damage to that alveoli. It can result because we're not inflating the lungs adequately, or because we're not using the proper amount of PEEP. And so we would need to address that, and we'll get into that in a little bit more detail later on. And three causes for atelectic trauma, or three ways that it can cause trauma, is we can cause shear stress from the opening and closing of those lung units repeatedly on each breath. Also, as it collapses, it can actually push out surfactant. So you get what we call a washout of surfactant. And so it alters our surfactant in that it decreases the amount, but we'll also discuss how it also alters the production of surfactant. And then we can cause injuries at the microvascular level. And so we will go on to talk about some of this. So shear stress, as I said, as the alveoli opens and closes, we want to try and keep it expanded and not have it collapse. And as I touched on earlier, we have areas of lung that could have a normally compliant alveoli next to an area which is diseased or less compliant. And as a result, the one with normal compliance is going to expand normally, and the one without normal compliance is not. And as a result, you're going to get this stress that occurs between the two, kind of pulling them apart, and it can cause this stress and cause the microvascular injury at the pulmonary level. So this next slide shows nicely, if you have on the left-hand side here, two normal alveoli next to each other, and they have communication between the pores of cone to talk to each other and help each other inflate and deflate. You will see that both the alveoli will inflate similarly to the same amount. Now, in the right-hand side, we have an alveoli here with normal compliance, and this one outlined in dark black has low compliance. So this would be a diseased alveolus, okay, which might be suffering from ARDS. So as we try to push gas in, gas is going to preferentially go into the normally compliant alveoli and inflate. It will also try to inflate the alveoli with poor compliance, and it will inflate a little bit. And some gas might actually get forced through the pores of cone and cause more inflation in this normally compliant area. And as a result, this black line here, you're getting the shear stress between the two, which is where the injury can occur between the two units. Okay, so surfactant alteration. When you have alveoli that are collapsing on exhalation and opening on inspiration, we have surfactant that gets squeezed out of the alveoli. And each time it collapses and is forced shut, it's squeezing more surfactant out. So each time this opening and closing is happening, we're losing more surfactant. Okay, so what is going to happen is as we lose surfactant, the alveoli is going to become less compliant. So it's going to become stiffer and more difficult to ventilate. And it becomes sort of a vicious cycle because, as I said, each time it opens and closes, it's going to force surfactant out, so it'll become less and less compliant. And so we can cause surfactant alteration. We talked about how we did it with underdistension. We can also affect it with overdistension, as the surfactant's going to have to cover more of an area on the lung and in that alveoli, more surface area, and it becomes less compliant as well. So our microvascular injury, we're talking in this injury about shear forces that are happening, and they happen at the corner of vessels. So they happen at the corner of microvascular vessels. So in here, you can see where we're talking about. And so if extreme negative pressures are occurring, it can cause these vessels to rupture, which we can see the rupture on the right-hand slide here. And it's going to cause spillage of fluid and inflammatory mediators into our interstitial spaces. And so as a result, it can lead to biotrauma. And so our biotrauma is a spillage of these chemical mediators that are released from our pulmonary cells when they're damaged and stressed, like we talked on the previous slide. And so as a result of these mediators, we're naturally going to increase our production of alveolar macrophages, and it's also going to increase the release of cytokines. And as a result, these chemical mediators will cause damage to the lungs, and that's what's going to result in our patient having sort of an ARDS lung. So the chemical mediators, if they spill into the systemic circulation, then they can actually result in multi-system organ failure. Okay, so this slide is sort of just showing the overall reaction of the cytokines being released and the macrophages and the inflammation that is going to cause our ARDS picture. Okay, and you can see it's with our shear force trauma that we talked about, over distension, and cyclic stretch, which is our alveoli collapsing and re-expanding on each breath. Okay, this slide is also showing the mechanisms of ventilator-induced lung injury. And on the left here, it's showing excessive stress and strain. We're using large distending forces. And so here you can see the damaged alveoli resulting from the stress and strain being placed on it, and it might result in volutrauma or barotrauma causing rupture. And once the rupture has occurred, you're going to see that biotrauma will then follow. On the right-hand side, we have our moderate distending force. And so our alveoli might have stress and strain from atelectasis, so the repeated opening and closing of those units. And so we get the washing out of surfactant, and you can see that the inflammatory cascade begins, and you're going to lead into the biotrauma that occurs and results in our ARDS type picture. The next thing we're going to talk about is air trapping. So if we're not conscious of how we are ventilating our patient, and if we're not looking at our waveforms to make sure that we are not causing gas trapping or air trapping, we can actually cause hemodynamic compromises. You're going to see mean arterial pressure increase. And if our patient is awake and participating in their ventilation, in making efforts on the ventilator, it can actually cause increased work of breathing due to the decreased compliance, and also it's going to be more difficult for them to initiate a breath by triggering the ventilator. So I have a waveform on the next slide. So when we're monitoring our waveforms on our ventilator, we usually have our pressure waveform, pressure and time. This one is our flow versus time scalar. And so this scalar is really important to show us if our patient is actually able to exhale all of the previous breath before initiating their next breath. And if they are not exhaling fully or emptying their lung units fully, gas is being left inside the alveolus, and on the next breath, we're adding a full volume in. And again, they won't have time to exhale fully, and so more gas gets trapped. So each breath, you're adding more and more volume remaining in the alveolus, which can result in volutrauma or barotrauma. As a result, you will also see on the ventilator, we have our set PEEP, but we also have measured PEEP. So you might see that your PEEP that is being measured is actually higher than that which is set on your ventilator. If you do not see that and you're unsure if there's air trapping, you can actually put an expiratory pause onto a breath, and it will measure for auto PEEP. So you simply, depending on the ventilator you're using, there should be a button that says expiratory hold. And once you press that button, it's going to do a measurement at the end of exhalation to determine the level of PEEP. And if the PEEP is higher than what is set, then you know there is air trapping occurring. Okay, so this dotted line here is what we actually want to see. So we want to see that at the end of exhalation, that our flow returns to 0 liters per minute before our next breath is being delivered. This solid line here is demonstrating air trapping or gas trapping. So you might hear one or the other. So as the patient's exhaling, so they still have air left, they haven't gotten all their air out, but now it's time for the ventilator to give the next breath, and it delivers the breath. And so you can see in here, there is an amount of volume that is remaining in the lung and being trapped. So now they get their next full breath and they go to exhale. I know this doesn't continue, so let's say on the next breath, this is their exhalation. Again, more gas is being trapped before the next one is being given. So if you actually see gas trapping, if we're in a pressure mode, so an ACPC mode, you can try to decrease your respiratory rate. That's the easiest way to address gas trapping or air trapping, because it will give the patient more time to exhale before our next breath is given. And that's because our inspiratory time is usually sort of a constant in a controlled mode. And our expiratory time is based on our total cycle time. So our total cycle time, so I'm just gonna go to a whiteboard for this. Okay, so when we look at our total cycle time, so I said our I time is usually a set value. Our exhalation time is gonna be based on the remaining time available. So we have 60 seconds in a minute, and we look at our set respiratory rate, which let's say is 12 seconds. or sorry, 12 breaths per minute. That gives us a total cycle time of 5 seconds. If we then do a total cycle time and we say we need more time to exhale, and we drop our respiratory rate to 10, 60 divided by 10 gives us 6 seconds. So it gives the patient an extra second of exhalation time. So when we look at that, that might be enough to resolve our exhalation time and get this patient to return to 0 liters per minute before our next breath is given. So that is the easiest way. We may need to make other adjustments to compensate for this change. So if we need to maintain our same minute ventilation, we may then need to go up on our tidal volume because our minute ventilation is a formula of our minute ventilation times our respiratory rate. So if we're decreasing our respiratory rate, we may need to increase our tidal volume. The other things that might make a difference, you could consider decreasing I time. So if we make our inspiration shorter, then we might give a little bit longer to increase our exhalation time. And if you're in a volume control mode, you can also consider increasing your peak flow rate. Some ventilators, you have the option of setting I time, which you would decrease the I time. In other ventilators, you set your peak flow rate. So if you increase your peak flow rate, you're going to deliver the breath faster, which is decreasing our inspiratory time. Okay, and the final injuries I want to touch on is oxygen toxicity. So in adults, adults can usually tolerate 50% oxygen for prolonged periods of time. But once we start getting into levels of 60% of oxygen for more than 48 hours, we know that we can cause toxicity to the pulmonary tissue. So it can cause changes in our pulmonary tissue, which will affect our compliance. If you are ventilating a patient on 100% FiO2, at 6 hours of ventilation at this FiO2, we're going to cause lung and tissue damage. So we need to be mindful that oxygen can cause lung damage. We don't want to leave our patient hypoxic, but we also want to be conservative and not overly aggressive with our FiO2s. So as you can see here, there's a whole host of things that oxygen toxicity can cause. So it can decrease our tracheal mucus flow, so the patient can't cough out secretions as easily. We're going to get macrophage activity, which can cause more biotrauma. It can affect our functional residual capacity in our lung, which is the volume remaining when we exhale. It can also impact our surfactant production, which will then affect our compliance. And it can also affect the ability for gases to move in and out of the bloodstream. Okay, we can also cause damage to our capillaries. It can cause platelets to clot together, to stick together, and it can cause endothelial cell damage. Okay, and finally, the last thing it can cause is it can also result in atelectasis. So in units that are underventilated or hypoventilated, they're susceptible to atelectasis if our FiO2s are higher than 70%. So maybe it's not that they need more oxygen at this point. Maybe we need to address their tidal volumes and get more tidal volume in to improve their ventilation. So it could be a shunt that is happening between their ventilation and perfusion. And if we improve that shunt, then we can hopefully avoid atelectasis, and maybe we can use less oxygen for that patient. I included work of breathing in here just to be inclusive. So again, I'm going to focus more on initiating ventilation and initiating lung protective ventilation. But we know that as we are weaning, we can increase work of breathing if we're not setting our triggers appropriately on our ventilator, which is resulting in a lag between the patient asking for a breath to be delivered to them and the ventilator recognizing that and actually delivering the breath. We also can impose work of breathing through our artificial airway, more likely in an endotracheal tube. So once we know where that endotracheal tube should be placed for ideal placement of 2 to 3 centimeters above the carina, and once it is actually secured and confirmed to be secured in that location, what we can do is we can shorten the length of the endotracheal tube to decrease how long that narrow radius that the patient has to pull air through is. So if we decrease that length of the tubing, we can decrease the work of breathing. The reason I stressed that you need to make sure the tube is properly placed before cutting the tube is because if it's too high up and you cut the tube, you may not have enough length to advance the tube down to where it needs to be placed ideally. And then you would be ending up in a situation where you need to replace the endotracheal tube. So always make sure your tube is in the correct place before you cut it to decrease work of breathing. And be mindful of the pilot line when you're cutting it, that you don't sever the pilot line, which inflates the balloon to allow for ventilation. Okay, so again, the 3 things that you can look at to reduce work of breathing is the artificial airway, which I just mentioned. Looking at the trigger sensitivity on our ventilator. So ventilators usually either allow you to set a pressure trigger or a flow trigger. Flow triggers are usually more are more ideal for the patient. It's easier for them to initiate a breath. And we also need to look at our patient ventilator synchrony. So now getting to why we're here. So how do we provide lung protective ventilation in a patient with ARDS, which is the presentation that COVID-19 patients are coming to the hospital with? So what is ARDS? So we've provided them with oxygen, but they still continue to exhibit hypoxemia. They're having severe shunting so that their gas exchange is compromised. We know they have a reduced compliance, so their lungs are stiffer and harder to ventilate. We also see on chest x-ray that there are bilateral infiltrates. And if you are using wedge pressures are usually less than 15 millimeters of mercury. But I know that's not as common a practice anymore. So that is based on the Berlin definition, which I also have a chart to break down the different categories for you. Mortality from ARDS still remains at 30 to 70%. And the reasons patients experience ARDS are numerous. So it could be from a direct injury to the lungs, or it could be an indirect injury, so secondary to how we're ventilating or what we're doing, or an inflammatory cascade. ARDS typically has two phases. One, which is early, when there's increase in vascular permeability, and the latter when they're after the vascular permeability, where the inflammatory cascade occurs. It then leads to extensive lung fibrosis, which causes our lungs to be less compliant and stiffer to ventilate. So here is the Berlin definition of ARDS. So the timing is usually within a week of a known clinical insult or a new or worsening respiratory symptoms. As I mentioned earlier, you might see bilateral opacities on chest X-ray. It may be effusions, it could be collapse, it could be nodules. The patient begins to experience edema, and it's they have respiratory failure, which isn't fully explained from a cardiac standpoint or from fluid overload. So in order to get an objective assessment, they need to perform an echocardiograph to exclude hydrostatic edema. And so if that is excluded, this is sort of our ARDS picture. Then when we look at oxygenation, it's going to classify our patient on whether they have mild, moderate, or severe ARDS. So you can see mild ARDS is 200 millimeters of mercury to 300 millimeters of mercury with a PEEP or CPAP of 5 centimeters or higher. Okay, and this is looking at our PF ratio, which is taking our PaO2 from arterial blood gas and dividing it by the FiO2 they were on when that blood gas was drawn. Moderate ARDS is less than 100 millimeters of mercury to equal to or less than 200. Again, on a PEEP of 5 centimeters of PEEP or higher. And severe is less than 100 millimeters of mercury on a PEEP of 5 centimeters or higher. So we don't always have a CT scan of a patient to understand if they have areas of their lungs that are collapsed and can be opened up. And we'll look at a way that we can assess that on the ventilator. But what I wanted to show here is, so on this top picture, we see these white areas here. So black is air and white is tissue or something more dense. Here you can see the spinal cord. So this is the patient's posterior, and then we can see some ribs. We can see the sternum here and the other set of ribs. So here you can see on the right side that there's air throughout the lung on this side. On this side of the lung, we end up with this consolidated area here that looks like it could be atelectasis. So this was at 5 centimeters of water pressure. So then they increased to 45 centimeters of water pressure, and this area remains as an opacity. So there's still some atelectasis, or it's still much more dense. Okay, so this patient is not showing that their lung units are what we call recruitable. In the bottom image, so we have a different patient on the left-hand side, again at 5 centimeters of water. So again, their posterior is down here. So here's their vertebral column. So again, you can see this consolidation here, and then we can see the air here, and we can see on the right side, it's very consolidated. And then they increased the pressure to 45 centimeters of water, and you can see that the lung is much more aerated. So there's much more black area showing air in the lungs. And you can see much more air on the right-hand side as compared to 5 centimeters of water. So this is what we would say is a recruitable lung, where we're able to open it up and actually ventilate it more. So in this bottom case, PEEP, the addition of PEEP might actually help open up these alveoli, whereas in our top patient, the addition of PEEP is not going to help open up any alveoli, so it might just cause more barotrauma to the lung. And so the PEEP is not going to help with oxygenation or ventilation at this point. So now I'm going to go into the different strategies of ventilation. And just as a note, on the previous slide, you do hear some people discussing with COVID-19 two different phenotypes, phenotype L and phenotype H. And that was in the early days. And again, it's referring to if the patient is not recruitable or if the patient does have recruitable lungs. So people are now moving to the format where they're just talking about patients with COVID-19 as an ARDS picture. Okay, so I'm going to talk about 3 different strategies for initiating ventilation on ARDS patients to keep lung protection in mind. So we're going to first use the ARDS or the ARDSNet protocol. Then we're going to look at the University Health Network hospital here in Toronto, Ontario. We're going to look at their protocol for ventilating, as it is similar but slightly different from ARDSNet. And then we're going to take a look at the Center of Excellence in Mechanical Ventilation and their recommendations. And so when we start talking about how to initiate ventilation on a patient for lung protective strategies, we start to consider the tidal volumes that we're going to use. And when we talk about lung protective strategies, we're generally talking about volumes of 4 to 6 milliliters per kilogram based off of ideal body weight or predicted body weight. So you can use whichever you prefer or whichever the protocol calls for. It comes out to a very close tidal volume for either calculation. So it's very small differences. But it's important to use ideal body weight or predicted body weight and not actual body weight, because the size of the patient's lungs don't change based off of their physical presentation. So if someone is extremely underweight or if they're obese, their lung size is still the same for their height and their age and their if they're male or female. The respiratory rate, we're going to see some different recommendations, but we know as we're getting ready to intubate, the patient is breathing at quite a high respiratory rate. So we need to keep in mind what our patient is doing at that time and what we're going to set them up on. So it may be something very similar, but we also need to be mindful of gas or air trapping in the lungs once we get them set up on it. We'll look at that in a bit more detail. And ABG goals, again, this might differ between the different protocols that I have here, but quite often they are allowing permissive hypercapnia in patients with ARDS in order to adequately or to effectively ventilate them and keep lung protective strategies. So we'll look at the different ABG goals as we go through these 3 different scenarios. We need to be aware that ARDS patients, we need to treat lungs as baby lungs. And so we'll talk about a baby lung on the next slide, but ARDS is rarely homogeneous, and that means it's not, the entire lung is not presenting with the same clinical picture. So it's what I was discussing earlier, it's a heterogeneous disease where you might have areas of the lungs where there's normal compliance next to areas of lungs that are the damaged components with poor compliance. So we need to be mindful of that because the areas with normal compliance we know will expand very easily, and we don't want to damage them by providing too much volume to them. So by using a lung protective strategy of the 4 to 6 mils per kilo, it's so that we can ventilate this baby lung without causing volume trauma. So 4 to 6 mils per kilo is specific to protective lung strategy. If someone was presenting with normal lungs, we generally use 6 to 8 mils per kilo to ventilate that individual. Okay, so our goal is to keep our P plateau, so our plateau pressure, less than 30 millimeters of mercury, and have adequate oxygenation at the same time. So here I have a picture or a CT again, showing our baby lung. So this is similar to the one I just showed. So you can see the atelectasis here. So these areas, it may be atelectasis, they may be reduced compliance. Okay, so if this is not recruitable, then this area of the lung is what's going to take on the volume. And so if we try to use 8 mils for a normal sized lung of, say, a patient, so we assume they have normal lungs for their size and height, their height and gender, then we're going to overinflate this area of this compliant lung. So what we're doing is we're reducing to 4 to 6 mils per kilo in order to ventilate this healthy area without causing excessive damage, because we know this area is not going to take on much of the volume. So moving into our ARDSNet guideline, for their guideline, they actually have you setting your tidal volume at 8 mils per kilo based on predicted body weight. And then you're going to titrate down from there depending on your plateau pressure. And they say for the respiratory rate, you want it as high as possible to achieve a target minute ventilation without causing auto PEEP. Okay, and so the modes that you can do, so it says select your mode depending on your need of keeping P-plat less than 30. So modes to consider when we're first initiating ventilation on these extremely sick individuals is volume control, so ACVC. We can do ACPC, so pressure control ventilation. And we can use a dual mode where we're having pressure regulated volume control. So those are good modes to think about using for lung protective ventilation. And I know someone else was discussing different modes with you, so I'm not going to go into the details on the modes specifically. So here is the ARDSNet protocol. You can see the link down below to access it. So it's a little nice 2-page protocol that we'll go through. So you can keep it clinically at the bedside if you need to refer to it. So it gives you your inclusion criteria for acute onset of ARDS. So it talks about your PF ratio, so which we discussed earlier, your PaO2 divided by your FiO2, keeping it less than or equal to 300. It talks about the bilateral, patchy, diffuse, or homogeneous infiltrates consistent with pulmonary edema. And there's no evidence of left atrial hypertension. So in order to set up the patient, you are going to calculate their predicted body weight. So you can see here, you have the calculation for males, and you notice that the height is in inches, okay? And then you have your formula here for females, again, height being in inches, so you need to be able to convert into inches. So as I mentioned on the previous slide, they allow you to choose the mode of ventilation that you desire. And you're going to initially set it up at 8 mils per kilogram based off of the predicted body weight you calculated. You're then going to reduce your tidal volume by 1 milliliter per kilogram at intervals of 2 hours or less until you reach 6 mils per kilo. Okay, so I'm gonna start at 8. My next ventilator change, I will then calculate what 7 mils per kilogram predicted body weight is, and I'll move down to that tidal volume. And then finally, I will calculate what 6 mils per kilogram predicted body weight is, and that will be my next change on my ventilator. So then they say you're going to use an initial rate to approximate your baseline minute ventilation, but do not go greater than 35 breaths per minute. Okay, so you're going to adjust, then you're going to adjust your tidal volume and respiratory rate to achieve your target pH and your plateau pressure. Okay, so our oxygenation goals, we are aiming to keep our PaO2 between 55 and 80 millimeters of mercury to minimize oxygen toxicity. And we are going to aim for an SpO2 of 88 to 95%. Okay, and so you're going to choose a strategy of lower PEEP, higher FiO2, or higher PEEP and lower FiO2. Now, really, this is so that we're moving in a way where we're not overusing PEEP or overusing FiO2. So it gives you sort of a way to think about moving up. So if I'm at 5 of PEEP and I'm already on 40%, maybe I should think of making PEEP 8 before I increase my FiO2 again. So it gives you a way to move in here. Once you get into higher PEEP, lower FiO2 strategies, it becomes a bit more difficult. You never really end up on this higher end because we're trying to keep our plateau pressures less than 30. So you might end up somewhere in this area of 12 to 16 centimeters of water PEEP. And again, FiO2's 40, 50%. We know once we get into our 60%, we're going to start causing lung damage. Okay, so once we've got our patients set up and ventilating, we're now going to check their plateau pressure. And so to do a plateau pressure, you actually need to be in a volume control mode, ACVC. So to make it easy on yourself, here it says select any ventilator mode. Knowing that you need to do plateau pressures, you might decide that you want to use volume control to ventilate with. And so they suggest that you set a plateau or an inspiratory pause. So it's a plateau time or P pause, usually written on the ventilator, of 0.5 seconds. And you're going to perform this pause maneuver at least every 4 hours or every time you make changes to PEEP or tidal volume. So If your P plateau is greater than 30, they want you to decrease your tidal volume by 1 mil per kilogram. But you need to stop once you get to 4 mils per kilo. We never ventilate with less than 4 mils per kilo because we will be hypoventilating our patients. The volumes become too small at that point. If the P plateau is less than 25 centimeters of water and your tidal volume is less than 6 mils per kilogram, they're saying try to go up to 7 mils per kilogram, see what your plateau pressure is. If it's still less than 25, you can go up again, but you're aiming to keep your P plateau greater than 25 centimeters of water, or trying to keep your tidal volumes at 6 mils per kilogram. Okay, if the P plat is less than 30 and breath stacking or dysynchrony occurs. So breath stacking is another term for air trapping or gas trapping. So one breath isn't finished emptying before the next breath is given. So each breath is being stacked upon each other. And dysynchrony is looking at our patient and our ventilator and looking at our waveforms, and it may be the patient's fighting the ventilator or is very uncomfortable. We need to make adjustments. So they're saying try to increase your tidal volume by 1 mil per kilogram, and to do that to 7 or 8 mils per kilo. But you still need to keep your plateau pressure less than 30 centimeters of water. Okay, so on this page, I'm just going to be going through this top little portion of ABG management. The remaining portion of this page becomes weaning the patient. So our goals for our pH is to maintain our pH between 7.3 and 7.45 if possible. So if our pH is less than 7.3, so for example, if it's 7.15 to 7.3, we're going to try and increase our respiratory rate slowly until our pH is greater than 7.3, or our PaCO2 is less than 25. And we're not going to increase our respiratory rate more than 35 breaths per minute. When we're making these changes, if our gas is 7.15, for example, we don't want to swing from 7.15 all the way to greater than 7.3. We're going to make changes slowly to move the patient there in a stepwise fashion. So I might increase my respiratory rate by 2 breaths per minute, wait, do an ABG, go another 2 breaths per minute, or add end tidal capnography onto your endotracheal tube, where you can trend your end tidal CO2 with your blood gases, so you're not having to take as many blood gases. But you're just going to slowly move. Every 20 to 30 minutes, you can make a change and slowly move after you've seen the results of the previous change. If our pH is less than 7.15 and our respiratory rate is at our max of 35, then you may need to increase by 1 mil per kilogram until our pH is greater than 7.15. And they're noting that you might have to exceed our plateau pressure target of 30 centimeters of water. Okay, here it says you might give bicarb. That's not as common a practice now, but it is something that can be considered and discussed amongst the team. Alkalosis management, if you're greater than 7.45, we're going to decrease our ventilation rate, and we're going to be less aggressive and cause less damage to the lungs, so we can keep them in a normal pH range. Our IE ratio, it's a goal, it's not an expectation, because our I time is what's set, but they recommend that the duration of inspiration, oh, sorry, this would be an expectation. Inspiration needs to be less than the amount of time spent in exhalation. If we get into inspiration being longer than exhalation, we are going to develop gas trapping or air trapping, breath stacking, all interchangeable words, and we're going to cause damage to the patient's lungs. Okay, the reason we're using PEEP in our strategy is that it can help prevent atelectasis. It can improve our shunt and improve compliance of the patient. So finding the appropriate PEEP, there's different approaches to the level of PEEP. So some people use optimum PEEP, some people use a PEEP targeted strategy. So ideally, what we want is our PEEP should be just above the inflection point on our pressure volume curve after the lung is maximally inflated. And it can be difficult to find that without proper equipment. So a lot of, some places are using esophageal balloons, but you need specific ventilators and you need to understand how to place the balloon. So it becomes very cumbersome if you do not have that equipment available for you. There are a couple other techniques that we'll look at today that you can pull on as a resource. So here we have a lung, and you can see this is during inflation on the top here, and this is during deflation on the bottom here. So as the breath goes in, the lung gets bigger, and as the breath goes out, the lung gets smaller. And so here we're looking at where is the lung opening. So here you can see there's not a lot of change in volume for the change in pressure. And then we get this lower inflection point here where the lung starts to inflate. However, as I said, you want to look at the lower inflection point on exhalation. So as we exhale back down, our lower inflection point is somewhere here, which would result in a PEEP of 3 or 4. So you can see here that the lung is staying inflated versus if you go to 0, it is deflated. Okay, so this is what it's referring to when it says the lower inflection point. Okay, and by keeping it open, the alveoli aren't collapsing and opening on each breath, so you're not getting that shearing and the loss of surfactant, so it's helping improve our lung compliance. We'll talk about airway opening pressures a little bit later, and there's a video to show you how to assess airway opening pressures. Okay, our oxygenation, again, we're going to follow our protocol for high PEEP, low FiO2 to maintain adequate oxygenation. Other things that can be considered if these strategies are failing are things such as high frequency oscillation, prone positioning, which again, I know the CSRT is having another individual talk about prone positioning. So that's a strategy that can help improve oxygenation. And if necessary, we can talk about an ECMO machine. So an extracorporeal membrane oxygenator machine. So the reason we do prone positioning again is to improve our ventilation perfusion ratio to decrease shunting. Okay, and that's when we're flipping them onto their stomach. Okay, so moving on to the University Health Network ventilation policy and procedure. It's very similar. So you can see they have within their policy an ARDS ventilation strategy. How it differs from ARDSNet is that they prefer to start in pressure controlled ventilation as the default mode. And if they want to deviate from this, they would need to be directed by the attending physician to use a different mode of ventilation. So their oxygenation goals are a little bit lower than what ARDSNet had. So they're saying to keep your saturations from 88 to 93%, again, unless directed by an attending physician. And they're happy with pHs greater than 7.25 unless directed otherwise. Okay, so those are slightly different to, and I would think it's to be less aggressive with the ventilation on the lungs, so we're causing less side effects. You can see instead of starting at 8 mils per kilo, they're starting in the lung protective range. So they have decided that when they set their inspiratory pressure, they're going to target a tidal volume equal to 6 mils per kilogram of predicted body weight. So that's a little different from ARDSNet. The plateau pressure, we want to keep it less than 30 centimeters of water, similar to ARDSNet. And the respiratory rate, again, less than 40 breaths per minute, but you would need to look for gas trapping or air trapping. Similar to ARDSNet, they do use the PEEP FiO2 chart to titrate. So you can see they have the similar chart put into their policy so that it directs you. Their PEEPs are a little bit different. So you can see here at 30%, they're already at a PEEP of 8 and moving to a PEEP of 10 before they move up to 40%. So they're moving a bit more quickly on their PEEP levels versus their FiO2 levels. They're trying to titrate to have an ITE of about 1 to 2, but ideally we're looking at getting adequate inspiratory time and adequate expiratory time. So this is not a hard, fast number, but if you can optimize it, it's nice to try and target a 1 to 2 ratio to ensure adequate time for inspiration, which is the 1, and adequate time for exhalation, which is the 2 parts here. Trigger, so they allow the RT to determine whether we would like to set a flow trigger or a pressure trigger. So this is the criteria. If the patient decides they want to take a breath, they need to meet certain criteria for the ventilator to recognize it. And generally speaking, the flow trigger is an easier way for the patient to recognize, or for the ventilator to recognize the patient's asking for a breath. However, we can also set a pressure trigger. And flow waveform, it should automatically be set to a decelerating ramp. We are in pressure control, so that is usually what it is set to. But if we are deviating from pressure control, say to a volume control breath, they would like you to use a decelerating ramp rather than a square waveform. Okay. So next is the recommendations from the Center of Excellence of Mechanical Ventilation in Toronto, Ontario at St. Michael's Hospital. And so this is the flow chart they have come up with the initial management for COVID-19. So we can see that our patient is having worsening oxygenation with a PF ratio or an SpO2 FiO2 ratio. So if you can't get a blood gas, they allow you to use a saturation instead, less than or equal to 150 millimeters of mercury. And other indications for intubation, such as hypercapnia, so they're showing signs of acidosis less than 7.3. their work of breathing is high, their mental status might be deteriorating. So they're saying you shouldn't wait, you should go ahead and intubate. And they would like you to initiate ventilation with 6 mils per kilogram based on predicted body weight. They start their PEEP out at 10 centimeters of water, and they're suggesting a respiratory rate of 25 breaths per minute. So they say you need to consider the patient's pre-intubation respiratory rate. So if they weren't breathing quite that fast, you don't have to start at 25. So you have some wiggle room for where to start your respiratory rate. Or if they were breathing much higher, you might want to start a little bit higher. They start FiO2 at 100% right away. And you would be titrating that once you get the patient set up on the ventilator. You wouldn't be leaving them on 100% for a prolonged amount of time. And you need to make sure that you're maintaining deep sedation, and you may even consider a neuromuscular blocking agent. So they would like you to first assess for airway opening pressure, which we're going to talk about. But if that's not possible, you can look at your inflation ratio, your RI ratio, your recruitment to inflation ratio, and still get a value for that without using airway opening pressure. So again, here you can try decremental PEEP studies. You can also test at 2 levels of PEEP. So whatever your hospital is comfortable with and your practitioners are comfortable with, so long as we're assessing that the PEEP is adequate and not excessive, and it's not impacting hemodynamics, that's what they want to look at. You also want to keep an eye on driving pressure, which we'll be assessing or talking about, and we'll also be looking at ABGs. Okay, so again, when we started out this algorithm, the patient may be already on FiO2 of 60% and they're not able to maintain it. Their saturation's greater than 90%. So they're talking about early intubation, and if the patient has septic shock or a pH less than 7.3, it brings you to this box as well to intubate. So after we've looked at this, we're going to assess, is our patient recruitable? And if they are, we're going to set higher PEEP to maintain the recruitment. And we're going to do that based on the airway opening pressure we looked at. And we're going to look at our PEEP FiO2 ratio. If they're not recruitable, we're going to keep our PEEP from 8 to 10 centimeters of water, so long as our plateau pressures are less than 30 centimeters of water. And the other thing we're going to consider for the people that who are non-recruitable is that we're going to consider proning if their PF ratio is less than 150. Okay, and here you can see the website that I got this algorithm from. And on it, I'm going to bring you there shortly. It has videos to show how to do the airway opening pressure that you can watch on your own time. So this is the video I was going to show. And it also has videos on how to calculate the RI ratio. Okay, so we've talked about if they're not recruitable. Going back to if they are recruitable, we're going to set higher PEEPs to keep our plateau pressure less than 30 centimeters of water. So currently we're ventilating at 6 mils per kilo. And if our plateau pressure is higher than 30 centimeters of water, we're going to go down to 5 mils per kilo and set that and assess our plateau pressure. If it's still higher than 30 centimeters of water, we can go down to 4 mils per kilo. But again, we're not going to go lower than 4 mils per kilo. That's the lowest that we will go to maintain effective ventilation. So once we've got them set up on plateau pressure less than 30 centimeters of water, we're going to collect an arterial blood gas 15 to 20 minutes after initiating ventilation. And so as we continue to manage the patient, we're going to assess the driving pressure, which we'll talk about, and we want to keep it less than 14. We're going to keep our respiratory rate to target a pH of 7.25 to 7.42. So again, a little bit of a different pH range compared to the previous two protocols. And our FiO2, we want to keep our PaO2 greater than 60, and our SATs 88 to 98%. Okay, and if we need to, if our PF ratio is less than 150, we can also consider proning this patient. The next slide I included, I don't know if it's being used, so I just included it just in case, but it's if your hospital is using high flow nasal cannulas. It talks about the ROX index and calculating our ROX index and if our patient is at risk and if we should be moving to consider intubating. So it adds in that additional portion to this. Otherwise, the flow chart is essentially the same. So things that they like to monitor at the Center of Excellence of Mechanical Ventilation is, again, they're going to keep their tidal volumes. They're going to target 4 to 8 mils per predicted body weight, but they like to start at 6 mils if possible. So sort of in the middle and then go from there. We're going to talk about driving pressures. They like to keep it less than 15. And our airway plateau pressure less than or equal to 28 to 30 centimeters of water. I'm not going to get into the occlusion pressures, esophageal or transpulmonary pressures in this topic. Okay, so our driving pressure is essentially looking at the pressure that we're using to inflate the lungs. So it's taking out any of the pressure from the small endotracheal tube, the pressure being forced in, and it's looking at the pressure that is being used to inflate the lung and actually being felt at the lung. So to assess driving pressure, we need to measure plateau pressure. So again, we need to be in a volume control mode, and we need to set a plateau pause. And again, at the Center of Excellence for Mechanical Ventilation, they recommend plateau pauses of 0.2 to 0.3 seconds because this is short enough that the patient doesn't realize they're having a breath hold. Or if you would like to use the ARDSNet recommendation of 0.5, you can do that as well. You don't want to make your plateau pressure too long because you can get an artificially low number. So we're going to take the plateau pressure, which is reflective of the pressure being measured at the alveoli at the end of inspiration, and we're going to subtract the PEEP that we're using. And so that change in pressure between PEEP and our plateau is what we call our driving pressure. And that's the pressure that will be felt inside the lungs and be causing barotrauma or volutrauma to the lungs. So they say you should target to keep it less than 15, but ideally, if you can keep it lower than 13, that's even better. So in order to calculate it, again, you need to be in the volume control mode. You need a constant flow waveform, and you can either set an inspiratory pause on each breath, or you can use the inspiratory pause maneuver button for a one-time measurement. Next is our airway opening pressure. And so for our airway opening pressure, we want to calculate where, or we want to record the value of where the alveoli is opening up to prevent that shear pressure from happening, of it collapsing on exhalation and reinflating on inspiration. So if we know what our airway opening pressure is, so the amount of pressure to pop open that alveoli, we know that if we set our PEEP at that level or higher, that we will not get atelectasis occurring. So in order to do that, you can go to the Center of Excellence of Mechanical Ventilation. So back here on my slide. And at the top, it gives you, it asks, you can select airway opening pressure, and there are videos on different types of ventilators between the Servo I, the PB840, and the PB980, I believe, to show you how to assess for your airway opening pressure. All right, so now we're going to continue with our recruitment to inflation ratio equation, which allows us to assess whether a patient is a recruitable patient or a non-recruiter. So if we know that they have recruitable lung unit, then we can target what we want our PEEP to be set at in order to open up those airways. So for the recruitment to inflation ratio, it's looking at the compliance of our recruitable lung. So our compliance of our recruitable lung being abbreviated here, and dividing it by the compliance of the respiratory system. And that is essentially our baby lung. And it looks at dividing those two things at our low PEEP value. So we do have an online calculator that can easily help you with that from a link on the Center of Excellence in Mechanical Ventilation. And so you need to do a few things. So the calculator is at this web link, which is associated with it. So Thomas Perano has created this link, and he works at the Center of Excellence of Mechanical Ventilation. So in order to calculate our RI ratio, you will need to use a volume control mode, and they suggest, as I said, a pause of 0.2 to 0.3 seconds in order for the patient not to be uncomfortable and cause dysynchrony. And you are going to use high PEEP in the recruitment maneuver, and it should be at least 5 centimeters above our airway opening pressure, providing that it keeps our plateau pressure less than 30. So if we know our airway opening pressure is at 5 centimeters of water, they're suggesting our high PEEP of the recruitment maneuver should be set at least at 10 centimeters of water. And then in the maneuver, when we change the PEEP, that should also be a 10 centimeter change in PEEP. During this maneuver, we're going to temporarily decrease the rate to 6 to 8 breaths per minute. And we're going to follow the steps from the video that we have linked. So I'm just opening up this website so you can see it. Okay, so here is our RI ratio calculator that we're going to be putting in a few different values into this calculator, and it will evaluate our recruitment to inflation ratio as we go along. Okay, if we pan to the top, if we pan to the bottom, here you can see the airway opening pressure on the Servo I. on the PB980, and on the PB840. Here you have the recruitment maneuver that we will just go into right now, see if we can play it without a lot of glitches.
For this calculator, you need to use the set tidal volume, and you need to observe exhaled volume during the maneuver, as well as plateau pressure, which can be measured in real time by using a short inspiratory pause, like 0.2 seconds. Reduce the respiratory rate to 8 breaths per minute to ensure there is no auto peep. Prepare for a peep drop of 10 centimeters of water. In this example, we're going from 15 down to 5. At the end of this breath, observe the exhaled tidal volume, 398, and then keep watching for the exhaled release volume, which is 818. Also, look at the plateau pressure and enter all of these values into the calculator as instructed. Return back to your previous settings.
Okay. So for your ease, I've listed out the steps in the video that Tom Perano just went through. And so you're going to need to document your set tidal volume. And then you're going to need to measure and record your exhaled tidal volume at the PEEP setting that you currently are on. Then you are going to decrease your PEEP setting all at once. So this is not a gradual change. So you saw he went from 15 down to 5 immediately. And then he measured and recorded the tidal volume when the PEEP switches from high to low. And you saw that it was a much larger volume. You also need to record your P plateau, and then you're going to enter the values on his RI calculator, which I showed you at before the video. Okay, so looking at the RI values from the video, I just wrote them down to make it easier for you to use as an example on his calculator. So his high PEEP is at 15. His low PEEP was 5. His tidal volume from high to low was 818. And the exhaled tidal volume at the high PEEP was 398 mils. His plateau pressure was 17. And so when you put those values into the calculator, leaving the airway opening pressure blank, as we did not have one, it gives you an RI index of 0.26. And an RI index greater than 0.5 means that there is potential for more lung recruitment in regards to the lung inflation. If it's less than 0.5, it shows that the lung is not recruitable. So in this example, we have a patient who is not recruitable and likely won't benefit from the use of additional PEEP. And so for their protocol, we will keep this individual at 8 to 10 centimeters of water. So the final thing I wanted to show you before doing a quick summary is this adult ventilator ARDS order set. So this is for an ARDS patient. And if you go to the link that is provided here, you can actually gain access to this. You can see they've created it for you to put your hospital name and logo. Then there's the patient data and the attending physician or the attending team, the date that you're using, the date that this is being implemented, the patient information, their registration number, gender and sex, or sorry, gender and age. Once you've predicted or calculated predicted body weight, you can enter it here. If you're unsure, you need to measure them and then calculate the predicted body weight. So this order set allows the doctor to tell you whether they would like you to use volume control, pressure control, or PRVC, or a different mode of ventilation. And then it goes into initiating ventilation between 6 and 8 mils per kilo and titrate down. So here they're saying 0.5 ml to 1 ml per kilogram every 1 to 2 hours if needed. And they want you to prevent acute acidosis. They want the end inspiratory pressure. So that's what EIP is on the, so it would be similar to your plateau pressure. So if it's greater than 30, you're going to decrease your tidal volume to as low as 4 mils per kilo. If your pH is less than 7.15, then we're going to go up on our tidal volume 1 mil per kilogram, as we've been talking about, up to 8 mils if needed. And if the end inspiratory pressure or the P plateau is still greater than 30, you're going to try and get the patient to a pH of 7.2. If there's severe asynchrony with the patient and sedation can't be increased, then you're allowed to move higher than 8 mils per kilogram to try and comfort or try to get the patient synchronous with the ventilator. If the end inspiratory pressure or plateau pressure and the tidal volume are less than 6 mils per kilogram, and they're asynchronous, then you're going to increase tidal volume to 6 mils per kilogram. And if you're using ACPC, adjust your inspiratory pressure or your pressure control to move your tidal volume to 6 mils per kilogram. Okay, so here again, they use plateau pressure here, and they're using a different abbreviation here. It's interchangeable. So we want our plateau pressures between 20 to 30 centimeters of water. And they're allowing the plateau pressure to be greater than 30 only if PEEP is greater than 20 centimeters of water or pH is less than 20. So they give you a range for your set respiratory rate. And typical starting rate is 20. Consider greater than 25 if they're really acidotic, or markedly increased resp rate before you intubated them. But again, you need to make sure there's no gas trapping once you get them on. And you're going to adjust your respiratory rate to try and target the minute ventilation to avoid air trapping, but to get an adequate minute ventilation to control your pH. Okay, so if your pH is less than 7.3, you're going to increase your respiratory rate. If your pH is greater than 7.45, you're going to drop your respiratory rate. Inspiratory times here, they're saying 0.7 to 0.85. However, so that is for this order set. For the other protocols, a typical I time for an adult is anywhere from 0.8 to 1.2. So you can keep that in mind as you're setting things. Peak flow rates, you're setting between 60 and 75 liters per minute for patient comfort. I avoid peak flow rate less than 50 liters per minute, so you're not causing air hunger in your patients. 60 is a nice measurement if you're going to be measuring compliance and resistance, as you need to change it into seconds. So the 60 does it for you, and it makes it a much easier calculation. So target pH, ideally 7.3 to 7.45. Less than 7.25 and PO2 less than 25, you might want to consider some bicarb. And less than 7.15, you are going to need to change your goals to achieve your ventilation to achieve a pH of 7.2. And again, think about possible bicarb. So then they've included the low PEEP, high FiO2 strategy and the high FiO2, low PEEP, or sorry, high PEEP, low FiO2 on the bottom, low PEEP, high FiO2 on top. So then you can see here, they can write in what they'd like you to maintain the PEEP at. They can write in your target ABGs. It gives you an idea of ABG gases, when to take, so initiating or immediately after intubation, every day for 7 days of protocol, or if they're acidotic, so it gives you an idea. So dead space, so you can use capnography if you like, and then it goes into a bit of the routine care. Some of this is, which is to help prevent ventilator-acquired pneumonia. When you click on this link, it will take you to the page where you can access this order set if your hospital chooses to use that. So when we first, just to summarize, when we first start to support our ARDS patients, we want the ventilator to provide all the necessary work for them so that they can rest and use their energy to recovering. So that usually means using a volume control or pressure control mode, or the best of both worlds, where we can regulate our pressure and target a specific volume by using a pressure regulated volume control mode. If they are apneic or acute ventilatory failure patients, they will absolutely need full ventilatory support, and we want to make sure that we are providing that for them. So just to quickly summarize, as I know you did have a topic on modes, but just to as a reminder in the summary, if we are setting an inspiratory pressure in pressure control, there are 2 ways we can initiate ventilation on this patient. So we could start in a volume control mode and get a plateau pressure measurement. We can then take that plateau pressure and set that as our inspiratory pressure on the ventilator. So our pressure controller inspiratory pressure. And then it should give you a close value for the tidal volume that you desire. You just may need to tweak the inspiratory pressure up or down by 1 or 2 centimeters of water to get the specific volume you desire. Or the other way you can initiate pressure control ventilation is that you want to start with a lower pressure so you don't cause barotrauma. You don't know how the patient's going to respond to the ventilator when you first put them on. So you're going to start at an inspiratory pressure or a pressure control of 10 centimeters of water. You're going to take a look at the tidal volume and slowly increase your inspiratory pressure or pressure control by 1 to 2 centimeters of water until you reach your desired tidal volume. Like I said, PRVC allows us to set a tidal volume that will be delivered to the patient, and it will limit how much pressure can be felt in the patient's lungs. So in order to get your set desired tidal volume, be sure that you're setting your high pressure alarm 10 above your PIP, because as you know from your other lecture, the high pressure alarm plays a role in the pressure limiting of this breath type. Mandatory tidal volumes. So in patients with normal healthy lungs, we tend to ventilate with 6 to 8 mils per kilogram of ideal body weight or predicted body weight. And, but in ARDS, you see that we are targeting a lung protective strategy of 4 to 6 mils per kilo. When we set up our tidal volumes, especially in ARDSNet that starts at 8 mils per kilo, if our plateau pressures are greater than 30 centimeters of water, we need to reduce our tidal volumes by 1 mil per kilogram to get our alveolar pressures to a safer level of 30 centimeters or less. Just for inclusion and in a bit of a bigger font, I've included the ARDSNet calculations for you. So they are here as a reminder. And to combat auto PEEP, we need to make sure that the patient is able to create enough negative pressure in order to draw the specific amount of flow or pressure from the circuit that is required for the ventilator to recognize the patient is asking for a breath. So as a rule of thumb, if you set your PEEP to 80% of your intrathoracic pressures and circuit pressures, this is usually enough to offset it. The other way to offset this work of breathing is to slowly increase your extrinsic PEEP and monitor your inspiratory efforts and watch your patient and watch when they're becoming more comfortable to trigger the ventilator. So initial settings. So we want to avoid our alveolar pressures greater than 30 centimeters of water. Again, a reminder that adult I times of 0.8 to 1.2 seconds is what's considered normal. And if I times are too long, you might see the pressure waveform showing a spike at the end of inspiration or your flow hitting 0 before it's cycling. And if in volume control, you may see signs of air hunger or flow starvation. And that is if your I times are too long or if your peak flow rates are too low. So again, I'm just going to move to the whiteboard quickly. So things you might see in pressure control, and forgive my squiggliness because I'm on a laptop computer that is upright. So this is pressure and this is time. And so what you might see, so we start at our PEEP and we're going up and we have our square waveform. And if I times too long, you might get this little inflection at the end, which is the patient's trying to force the breath out. So you get this little inflection of pressure showing that the patient's trying to exhale, but they can't exhale as the valve hasn't opened up to allow them to. And what you might see on your flow waveform for pressure control, if, again, forgive me for the squigglies, if your I time is too long, so this is flow and this is time. So this is flow. So our flow starts at 0. So say I'm right on top. Our flow goes up and it degrades down. And if it becomes flat before it goes into exhalation, this time here is showing that the lungs are full and that the TI is too big. So it's too big. And so if you shorten your TI, ideally what you want to see, so I'm just going to erase these again. What you do want to see on your pressure waveform, or sorry, on your flow waveform. So this is your flow again, and this is your time. So what you should see on a flow waveform in pressure control is that the flow comes close to 0 on inspiration, but doesn't sit and hit 0. Okay, so our flow waveform is good not only for looking for breath holds on inspiration, but our air trapping on exhalation. And if you're in a volume control mode, We need to make sure we're setting adequate flow rates for our patient. So what you'll see on the pressure waveform in volume control, so this is pressure, this is time, so again, our pressure is starting out at a level of PEEP, and you might see a level of scooping. So usually, so let's see, I'll do it in red. Usually our waveform should be like a wave in the ocean. But now you see on here, oops, erase that, I thought I changed color. So here, this scooping is actually the patient sucking air out of the circuit limb of the ventilator and causing a drop in pressure. And depending how air hungry is how big this scooping is. So it could be all the way up. You see a big concave, it could be mild. So the extent of the scooping will tell you the extent of your air hunger. Okay, and as I mentioned, in volume control, it's a flow controlled breath. So depending on your ventilator, for flow controlled, you either set a peak flow rate or a I time. And so when we talk about our inspiratory pauses to do a plateau pressure, we don't want to set those higher than 10% of our I time. So again, 0.2 to 0.3 is short enough that the brain doesn't recognize the pause and will not cause asynchrony. And so it allows you to even leave this pause on every single breath and allow you to assess resistance and static compliance breath to breath, so long as you choose a constant flow pattern, so a square waveform. And again, just to finish up our final slide, triggering, again, is going to help minimize the work of the patient while avoiding auto-cycling. So it is possible to set our trigger too sensitive that someone touching the circuit or water in the circuit could be detected as a patient effort. So you really do need to watch your patient and watch the ventilator as you're setting your trigger. In a flow trigger, 2 to 3 liters per minute is a common starting spot, and pressure trigger, same pressure trigger of about 2 centimeters of water. Okay. And you do need to be mindful of the pressure settings between ventilators because some are actually in liters per minute and some are arbitrary values. So you have to know what is more or less sensitive on each of your ventilators. Thank you, and that ends my topic for today.